I'm John Pandolfino, the current president of the American Neurogastroenterology and Motility Society, and I would like to welcome everyone to the virtual symposia on neuromodulation. Better Together, Bridging the Divide Between Pediatrics and Adult GI Motility Disorders. My first job tonight is to introduce our moderator this evening, Dr. Prasanna Kapavarapu. He's an assistant professor at the Children's Hospital of Philadelphia with the University of Pennsylvania in Philadelphia. He's part of the CHOP pediatric motility team with a strong clinical and research interest in pediatric colorectal disorders. Prasanna, please take it away.
Thank you, Dr. Pandolfino, for the introduction. Welcome, everyone, to our ANMS virtual symposium today on neuromodulation. We have a great lineup of talks. The first talk is going to be on vagal nerve stimulation, hope or hype, by Dr. Kovacic. Dr. Kovacic is an associate professor at Children's Wisconsin Hospital and the director of pediatric GI motility and cyclic vomiting syndrome programs. She has established an auricular neurostimulation program and directs a multi-center registry for this therapy. She's funded by the NIH through a mentored career grant for her research on neurostimulation therapy and characterization of patients with chronic nausea. Dr. Kovacic.
All right, I think people can see me. So again, thanks for that introduction. I'm Katja Kovacic, and I will be speaking today about vagal nerve stimulation technique, especially through the auricle of the ear. Is it hope or hype? So these are my disclosures, which is not relevant to today's presentation. I will be reviewing the mechanism of auricular neurostimulation and some data on transcutaneous auricular neurostimulation therapies, and then go into the specific auricular percutaneous electrical nerve field stimulation, or PENFS, as I'm going to refer to it. I will then talk a little bit about our mechanistic data and the efficacy in functional abdominal pain disorders, and then as well as our ongoing research. So as you know, there is a lot of complexity going on between the brain and the gut signaling in functional GI disorders, and many triggers for these disorders. The triggers for these aberrant brain-gut signals are often the specific targets of our therapies. But our therapies are not frequently that specific. We use a lot of pharmacological neuromodulators to target the neuronal signaling, but affect many different receptors in the central and autonomic nervous system. And then we use also a variety of novel or more promising alternative therapies, such as CBT, hypnosis, and biofeedback, that influence higher cortical centers and may certainly have very beneficial effects on the brain-gut signaling. We also use more gastric targeted therapies with stomach relaxant drugs, prokinetics, and gastric electric stimulation, as Peter Liu will talk about later. But how about directly affecting the autonomic nervous system, those vagal afferent signals that travel between the brain and the gut? So this is what we're gonna, I'm gonna touch on today. And why the autonomic nervous system? Well, we all know that the ANS controls automatic and involuntary function of many viscera, and is primarily involved in maintaining homeostasis of the internal environment of the body. And there's a lot of data from heart rate variability studies, in particular on autonomic nervous system dysfunction in functional GI disorders. A lot of studies on IBS. Unfortunately, there's differences in methodology on these studies, and sometimes therefore differing and sometimes even contradictory results. And this is also, to remember, a surrogate of the autonomic nervous system measures, or the vagal tone. With these studies on heart rate variabilities, we are measuring cardiac vagal tone. So it's sort of an indirect measure of the ANS here. But there is, in fact, several meta-analyses showing reduced parasympathetic or vagal tone in functional somatic syndrome, as well as in IBS. So Interestingly, the ear has a specific innervation that can, as far as the vagus nerve, there are several cranial nerves that branch out to the outer ear, including the trigeminal, facial, glossopharyngeal, and specifically of our interest is the vagus nerve and the auricular branch of the vagus nerve. Rat studies, and there are several that inject tracer into peripheral ganglia of these cranial nerves, show actually that these central projections of these efferent axons distribute into the brainstem NTS, or nucleus tractus solitarius. And so the central effects associated with stimulating the outer ear may actually involve activation of NTS, specifically by the auricular branch of the vagus nerve afferents. So NTS activation, as you perhaps can imagine, can really activate higher cortical centers through many different pathways that we can't get into today. But it's closely connected to limbic system in the brain, as well as the dorsal nucleus of the vagus, which has efferent projections to the viscera, including the gut. So this is how we can see that influencing the brainstem, we can perhaps influence these signals to the gut. So there is data on non-invasive transcutaneous vagal nerve stimulators. There's been several different devices, particularly this one depicted here, that show interesting effects. This study was done in healthy controls in adults and showing increased thresholds for pain and several measures of pain using a transcutaneous vagal nerve stimulator applied to the outer ear. There is multiple other studies that are quite rigorous. There is a 12-week study in major depressive disorders in adults that showed efficacy of transcutaneous VNS for major depression. And then another healthy control study that showed reduced sympathetic nerve activity by stimulating the outer ear. This study by Frangus is an fMRI study that showed that non-invasive access through the vagus nerve from the auricle actually has affects central vagal projections and activation of the NTS. And this is specifically by activating this or stimulating the Simba concha in the ear. So that's the part of the inner ear that is affected by this type of device. And this was compared to earlobe stimulation, which did not have those effects. So there's other fMRI studies as well, a sham-controlled study showing that there's signal decreases in the locus coeruleus and the NTS, stimulating this same area. And then there is a study, this by Fang et al., that showed functional connectivity changes and increases between the prefrontal cortex and the default mode in major depression. So there's quite a bit of data out there if you start looking at transcutaneous vagal nerve stimulators. So what about this PENFS? So how's that different? So this is a percutaneously placed device, comes in a little package that's fairly simple to do. But a trained person needs to do, you have to be certified and trained, takes about 10 minutes, but it provides more of a field stimulation to the ear. So as you can see from the left picture there, you do not place a lobe with this particular device and a lead inside of the ear, but it's more field stimulation of the entire ear. So there are 3 points on the front and 1 stimulation point in the back of the ear. And this device is worn for 5 days at a time, 24/7, contrary to those other transcutaneous stimulators, which are typically done for a couple hours every day. So this perhaps provides deeper penetration of that tissue, perhaps better nerve stimulation, and the device frequencies are cycling and also cycles on and off during those 5 days. The idea being that you don't saturate the nerve too much stimulation. You cannot alter the settings with this current device. And then there's animal studies that I'm going to briefly touch up on. So again, 5 days worn every week, then 2 days off, more of a sort of for convenience purposes it's not so easy to have something on the ear all the time. You're worn 24/7, you can continue all normal activities except you cannot swim. We've done research studies when anywhere from 4 to 8 weeks of consecutive therapy where you come back for a new device placement every week. So as far as the animal data, there is one study using this particular device, in an animal model of visceral and somatic hyperalgesia. So So these rats received TNBS to mimic colitis, followed by PENFS therapy versus a sham device without electrical stimulation. And visceromotor response to colonic distension was measured via EMG at baseline after TNBS and after the stimulator PENFS. So, so rats that, I'll show that in the next slide actually, but rats that received the therapy had much lower response to colorectal distension. So there were also recordings from single neurons in amygdala and lumbar spine done in this study, which I'll show. So here on the bottom part of the graph, you can see that the colitis and active treatment in the squares actually had lower responses again to the colorectal distension at pressures over 30, and this was significantly different from the colitis with the sham device. This suggests the prevention of visceral hyperalgesia, and again in a smaller rat study, but still encouraging data. This is a single neuron recording from the amygdala in response to neurostimulation. The upper part shows a baseline, a histogram, frequency histogram. And on the left, you see a baseline response of the firing. And the middle one, again, is another depiction of the action potential, actually. And to the right, you see what happens after the stimulation. So the baseline response or the firing, these neurons in the amygdala are significantly suppressed, as seen on the right, after only 15 minutes of stimulation, which is interesting. And on the bottom, you see the response and the duration of a paw pinch that's applied. And you can see that after the auricular stimulation, the response to the paw pinch and that action potential is much lower. So this is encouraging animal data as to mechanisms of central effects, and there were also effects seen and reduction of the firing of spinal cord neurons. So that's an interesting study. We published our clinical trial in 2017, which was the first study on using this device in humans. And this was published in The Lancet. I'm going to quickly go through what we found. This study was done in 104 adolescents, 11 to 18 years of age, and they all had a functional abdominal pain disorder, any of or several of those, based on Rome 3 criteria. It was a double-blind study, just like in the rats. Half of the subjects received 4 weeks of a sham device that was completely identical, including the weight, including a battery inside, but the battery was not connected. Outcomes were pain, well-being, and disability. And FDA, based on adult trials in by the FDA, there's a 30% cutoff for what is a significant improvement in pain. So we use this cutoff to see how many had greater than 30% improvement in the pain. So the pain was measured after 3 weeks of therapy only in this 4-week trial, and that was simply logistics because the patients did not return after 4 weeks. And you can see the worst pain scores improved greater than 30% in about 60% of the participants compared to the sham, about 20% response. And similar with the usual pain scores, 58% in the treatment group improved greater than 30%. So perhaps not a cure, but the short duration of a few weeks of therapy provided some significant pain relief for these adolescents. Very interestingly, the PENFS group in the red graph had an improvement in functioning based on the functional disability inventory, which is a very objective measure of patients' disability and day-to-day activities. And there was a 36% improvement in the active treatment arm compared to none in sham. And this was measured 2 to 3 months after the end of the study, so at follow-up. So that is what I like to point out. This is suggesting some long-lasting effects of this therapy. Of course, there are some confounders where other therapies were not held after the end of the study. I also like to point out, which often gets forgotten, that these patients were very complicated. These were not just simple IBS and treatment-naive patients. The average number of medications previously tried and failed were 4 and 6, and those are pharmacological agents, prescription drugs. So this was an impressively complex group cohort that we actually saw nice improvement in. and pointing out that there's really no serious adverse events reported to date with this therapy. Most commonly and quite common is some ear discomfort, but if you educate and prep the subjects for this and alter the electrode placement slightly as after you place it or even later, if it shifts a little bit, it can seem to irritate a nerve ending. You can see redness in the ear, but actually I've never seen an infection yet. These are all sort of allergic reactions or adhesive allergies that patients also usually know ahead of time, and you could get around this by using hypoallergenic methods. Cosmetics is obviously a little bit of an issue, needle phobia as well, but they're not truly needles. These are 2 millimeter small pins that just barely enters the skin, so it doesn't really hurt even with the placement. We've done it as low as 5 years of age in little children. Lower than that, I frequently get the question asked, why don't we do, can we do it even younger? But a 3-year-old's not gonna keep this on, they're gonna rip it off. And this is why I do this. It's a very exciting patient satisfaction with this type of therapy and alternative therapy. But we had huge patient satisfaction in this first clinical trial. So what about the mechanisms? So we've just published this paper, Impaired Vagal Efficiency Predicts Auricular Nerve Stimulation Response in Adolescent Functional Abdominal Pain Disorders. So from the same cohort, we performed these heart rate variability measurements pre and post therapy, as I hinted to earlier. Working with founder of the polyvagal theory, Dr. Porges. He has come up with the index respiratory sinus arrhythmia. This is a measure of the vagal tone. It's an index of parasympathetic activity. It has been used in many studies, and it's a surrogate of cardiac vagal regulation. It's a pretty good measure of the efferent output of the brainstem ventral vagal complex and the brainstem control of the heart. And we can think about this measure and the vagal efficiency measure, as I'm going to just talk about briefly. That is another somewhat complicated index that has been derived from the RSA that sort of measures how the body can control heart rate, and the vagal tone from the brainstem really can continue to provide homeostasis and control that heart. So we talk about the vagal brake on the heart as a measure of this, as this vagal efficiency measure. I urge you to read this paper. It has some interesting findings. We find that low patients with low vagal efficiency, so think about them as having poor vagal tone. So there's a cohort in this study that have a reduced vagal tone. They did the best. So can this vagal efficiency measure perhaps be used as a predictor of improved pain after PNFS therapy? It certainly is interesting, and this is a measure that can be captured with a 10-minute EKG, and the patients go through some quick posture stressors that gets the heart rate goes up, and that's enough of a posture shift is enough of a stressor to pick up these findings. So it certainly looks like, based on this first study of about 100 patients, that vagal neuromodulation is a plausible mechanism. And putting it together with all the evidence from the transcutaneous vagal nerve stimulator data and the brain and effects on vagal nerve projections, it certainly appears that stimulating the outer ear can have vagal nerve stimulation effects. So quickly about our ongoing research at the Medical College of Wisconsin, we, as was mentioned, we are running a multi-center clinical registry with multiple large centers involved. We're capturing data on using this therapy, which is spreading quite rapidly among different centers. So we hope to provide very rigorous data from this multi-center registry pretty soon. I have a study on neuromodulation and characterization of patients with chronic nausea. We've just finishing a pilot study of this therapy for cyclic vomiting syndrome, and those results look very encouraging, although it's not a control study. And then we're doing further mechanistic studies. There's a young child, only 9 years of age, who's wearing this device and done extremely well with it, a cyclic vomiting patient. So this nausea trial is an NIH-funded trial. We're enrolling patients 11 to 18 years of age. They get 8 weeks of therapy, where the first 4 weeks of sham controlled, and the next 4 weeks are active therapy. And we're looking at several measures. We are looking at some gastric physiology with the gastric emptying breath test, the satiety test, the same vagal function measures, and also doing fMRI studies before and after on a subset. So 75% patients are enrolled to date. So in summary, animal and human data on vagal neuromodulation effects via the article does exist. The PENFS device animal data shows improved visceral sensitivity and effects on central nervous system, and very encouraging and sort of matches with the clinical effects that we are seeing so far. Randomized controlled trial in adolescents show efficacy in functional abdominal pain disorder, and based on this trial, a sub-analysis that we also have recently published led to an FDA approval for irritable bowel syndrome in adolescents. So that is also very exciting. A subset with suboptimal vagal tone have the greatest improvement. And our ongoing research is focusing on nausea and vomiting disorder and mechanistic studies. So hope or hype, there's certainly some hype to these novel neurostimulation techniques, and it's not going to be the cure for all. But with this data, I feel that there's a lot of hope at non-pharmacological therapies coming up, which is obviously the topic today. So thank you very much, and I'm going to give it over to the next person.
I just want to remind all our viewers today that please type in your questions in the Q&A section. And at the end of all the 3 talks, we will have a panelist respond to your questions. Moving on to our second talk for this evening, Dr. Lu. Dr. Lu will be talking on gastric electric stimulation, developing an approach. Dr. Lu is a pediatric gastroenterologist and research director of the GI Motility Center at Nationwide Children's Hospital. He's an assistant professor at the Ohio State University College of Medicine. Dr. Lu has a special interest in neuromodulation of the GI tract. Dr. Lu?
All right. So hello, everyone. I'm Peter Lu. I'm a pediatric gastroenterologist at Nationwide Children's Hospital in Columbus, Ohio. And I'd like to thank the NMS for giving me the opportunity to talk about gastric electrical stimulation. Here are my disclosures. So over the next 15 minutes, we'll answer 4 questions. What is gastric electrical stimulation? What is the evidence for GES treatment? How can temporary GES be used in patient selection? And finally, how can we develop an approach for using GES at our own institutions? So first of all, what is gastric electrical stimulation? So GES involves high frequency, low energy electrical stimulation delivered by electrodes that are implanted along the greater curvature of the stomach. These electrodes are connected to an implanted pulse generator and battery, typically implanted into a subcutaneous pocket in the abdominal wall. Here's an X-ray of one of our patients who has the device in place, and this is what the stimulator looks like. So I wanted to go through a patient case that I think illustrates the potential of GES. So a few years ago, I met this 2-year-old with recurrent vomiting and feeding intolerance. She had a severe infection in infancy that required a prolonged stay in the ICU, led to chronic GI, lung, renal, and neurological injury. When we met, she was unable to tolerate even slow continuous feeding by GJ tube. She was fully TPN dependent and had been tried on over a dozen medications for her vomiting. She had undergone endoscopic pyloric Botox injection twice. And she had a very thorough evaluation even before she met us, including a gastric emptying study that showed some delay of emptying of liquids. We did end up performing intraduodenal and colonic manometry in this patient, in part to make sure we weren't, in part to look for signs of pediatric intestinal pseudoobstruction, but her small bowel and colonic motility were generally normal. So with a growing concern for recurrent central line-associated bloodstream infections, we started to think about what other options we had and asked the question whether gastric electrical stimulation would be an option for her. So what is the evidence for GES in adults and children? So even though there have been 20 to 30 plus prospective studies looking at GES treatment in adults and children, only 4 have been controlled. So the first was published in 2003 by Dr. Tom Abel, and he did find that there was significant improvement in vomiting frequency when the stimulator was on compared to off. The next 2 were published by Dr. McCollum, and they did not find significant improvement in their primary outcome of vomiting frequency, although there were some other improvements found. And in retrospect, I think there's some thought that an initial 6-week period where the stimulator is off before randomization, that period may have affected the crossover periods. The most recent controlled study was published just earlier this year, and it involved, the design involved a one-month period where the device remained off before randomization to 4-month periods of the device on or off. And they did find significant improvement in vomiting frequency when the device was on compared to off, and that was in their whole group of 172 patients, but also when that group was split up by diabetes status. I think that degree of improvement is even more impressive when we think about the refractory nature of the symptoms that they were treating. What about in children? So unfortunately in children, there are only 6 studies from 4 institutions. 2 of those are from our institution, none of them are controlled. If you put them all together, we describe about 100 children treated with permanent GES, so that's where it's implanted. I think overall, there's probably closer to 200 to 300 children who've been treated around the country. Mostly these are female children. They range in age from 2 to 18 years of age. They all have severe nausea and vomiting with or without gastroparesis. These are severe patients. Most of them require tube feeding or parenteral nutrition, and all 6 studies describe significant improvement in symptoms. So what is our experience? So we last reviewed our prospective registry last year. At that time, we had 85 children who were treated with GES, mostly females, mostly adolescents. Almost all of them have been diagnosed with gastroparesis, but when we repeated their gastric emptying, only 63% had continued documented delay in gastric emptying. And we followed them for a median of 3.8 years. And I think this figure captures what I think is the most impressive response that we can see with GES, and that's their tolerance of feeding. So not only did we see significant clinical improvement in symptoms, even starting at 1 month after starting GES treatment, we could see even an improvement in oral tolerance by then as well. So if you focus on the center of the figure, so at baseline, about 30% of our patients were getting all their nutrition by mouth, and at 1 month, over 60% were getting all their nutrition by mouth. So overall, tube feeding or parenteral nutrition use decreased from 73% to 30% after GES. However, 18% did have complications, primarily related to discomfort, and 38% required battery replacement in that follow-up time period. That being said, we called our families after a median of 5 years, and 96% of families reported benefit, and 98% would repeat their decision to start GES treatment, which I think is a lot higher probably than a lot more, many other more established treatments. So it does raise the question of whether children respond better than adults. And there are some, including Dr. Abel, who has more experience treating children and adults than probably anyone else. There are some people who believe that children do respond better. And I think there are some potential reasons why that may be the case. So certainly children have fewer comorbidities. Our cohorts are much less likely to have diabetes or chronic opioid use. Environment is also different. So for most of our children, they have supportive families that are supporting them throughout this process. Potentially there's some differences in pathophysiology as well. So certainly the duration of symptoms for our patients is going to be shorter than for adult patients. Potentially that longer duration of symptoms is going to lead to some changes that are less reversible than for our children. And then finally, placebo effects. So I think it's hard to say whether children or adults are more susceptible to placebo effect, but I would argue that for young patients like the 2-year-old that we're talking about, I think the role of placebo effect is very small for someone so young who's already been through multiple procedures. So one reason why I think GES has not been more widely accepted, I mean, it's been around for over 2 decades, is that our understanding of how it works is still growing. So we knew early on that gastric electrical stimulation does not entrain gastric muscle, unlike a cardiac pacemaker. GES doesn't always improve gastric emptying, although it can in those with a baseline delay. And recently, Dr. Abel published a study describing an early and sustained antiemetic effect an early anti-gastric arrhythmic effect. A late autonomic effect is measured by looking at heart rate variability, and also some hormonal and anti-inflammatory effects. I think what we care most about is how do we predict who's going to respond to this somewhat invasive treatment. So we recently looked through our cohort again, trying to find baseline factors associated with the response. And unfortunately, all we found was that higher vomiting severity was associated with response, but not whether the patient was a child or teenager, or whether they had really bad pain, or whether they had delayed gastric emptying or small bowel dysmotility. And that was similar to a recent study of over 300 adults who have been treated with GES, where this is from the Gastroparesis Clinical Research Consortium, where they found that higher baseline GCSI was associated with response, but not the other factors that they looked at. So if we have very limited data in children and we're not really sure who responds, how can we justify using this treatment in a young child? So that's where temporary gastric electrical stimulation comes into play. So at our institution and several others, we require a trial of temporary GES before deciding whether to implant the stimulator. So that involves placement of a lead, usually by the nose for us, sometimes through gastrostomy, and then that lead is endoscopically secured to the gastric mucosa. The lead's hooked up to the stimulator, that stimulator remains outside the body, and then it's turned on, and then we monitor symptoms plus or minus physiologic measurements for 1 to 2 weeks. And then if there is a clear response, then we decide to move on with implantation. This picture is a beautifully illustrated depiction of the technique that we now use. It was drawn by Dr. Des Jacob, one of my colleagues, who also created this technique called the crossover die loop, or CD-low technique. It involves tying sutures and then using clips on those sutures to secure the lead to the mucosa. It is named after Carlo Di Lorenzo, our fearless leader and division chief. This is what it looks like on the inside. So you see the lead coming in from the left side, and then we have a combination of clips and sutures that are trying to push the lead and hold it against the gastric mucosa. So what has our experience been with these trials? So based on our data and also data from Dr. Salim Islam, a surgeon from Florida who's done a ton of these, about 68 to 91% of children respond and then undergo permanent implantation. But some of that variability is going to be because of variability in how these trials are done. So in a recent survey we did of 27 physicians who used GES, just over half used it routinely or consistently. The duration of our trials varied from 3 to 21 days, and the things that we were monitoring was a little bit different between the different groups. So back to our case. So like I mentioned, when we first met, this patient was fully dependent on TPN. She was retching pretty much throughout the day and would vomit 20 to 30 times a day. We started this trial, and within the first 3 days, her retching and vomiting stopped. In that first 2 weeks, she had 1 episode of vomiting. After talking to the family, we decided to prolong how long we did that trial. Unfortunately, she was admitted to the local children's hospital 3 weeks later. And then while she was getting admitted, mom noticed that the lead had come out of the stimulator. We did end up implanting the stimulator. She again had a very significant clear response. We were able to steadily advance her to full gastric boluses, and she had her central line removed 4 months later. So certainly that's not the end of the story, but she still is on gastric bolus feeds, working on oral intake with a therapist. But there are times especially with viral infections, when the vomiting can come back, and we may have to adjust medications until that goes away. So how can we develop an approach for using GES in our own institutions? So this tiny picture is our institution's protocol that we made a few years ago. And certainly we do not have the perfect approach, but just a few thoughts. So first of all, building the team. So for us GI doctors, it's critical to enlist the help of a surgeon who's just as passionate about gastric electrical stimulation as you are. We've been fortunate to work with some excellent pediatric surgeons, currently Dr. Karen Diefenbach, formerly Dr. Steve Teich. We've also enlisted the help of one of our GI psychologists, especially in that initial evaluation period. And that's because early on we had some negative experiences with patients who ultimately were found to have an eating disorder. So now we require a thorough psychology evaluation, including specific screening for eating disorders in the beginning. We do ask for a recent upper GI. We've had a few patients where the upper GI found a large hiatal hernia or other structural issue that had to be dealt with before doing the trial. We do ask for, we do perform baseline gastric emptying studies, even though we know they don't necessarily correlate with response. Sometimes we'll do an antrodural manometry or EGG before the trial. More recently, we have been asking for ultrasounds as a screen for median arcuate ligament syndrome, really more for those who have pain predominant symptoms rather than nausea and vomiting predominant symptoms. For the trial, I think it's important to figure out, what data do you want to collect? How frequently do you want to collect it? And then how long is that trial going to be? But perhaps most important is deciding as a group and also with each individual patient and family, what are the criteria going to be for what you're going to call a response? Like how much improvement do we have to see to move on to implantation? I recommend creating a prospective registry early on. I think that's been very helpful for us to help improve our process, but also facilitate research. And finally, collaboration. So Dr. Abel has organized these annual GS meetings at DDW. Unfortunately, this year's was postponed, but they have been really, really helpful for establishing collaborative relationships and also doing studies like that survey I mentioned before. We are creating a multi-center GS registry for both adults and pediatric patients treated with GS. It's going to be housed in REDCap, and institutions can use that to track their own data. It should be ready in the next couple months. So if you're interested in joining, let me know. I want to thank everyone who helped build the program and also our trainees who helped us learn from our patients. And thank you. I'm looking forward to taking any questions.
Thank you, Dr. Lu, for the wonderful presentation. Moving on, our last talk for today is on neuromodulation for anorectal disorders by Dr. Satish Rao. Dr. Satish Rao needs no introduction, but I would like to read out. Dr. Rao had spent 20 years at Iowa, where he was the tenured professor of medicine and director of neurogastroenterology and GI motility and biofeedback program with the Department of Internal Medicine at the University of Iowa Carver College of Medicine. Later, Dr. Rao moved to Medical College of Georgia in Augusta, where he's a tenured professor of medicine with the Division of GI Hepatology, and is also the founding director of Digestive Health Center. Dr. Rao is one of a rare breed of academicians who has excelled as an outstanding researcher, distinguished educator, and as a master clinician. Dr. Rao's research interests focus on the pathophysiology and treatment of IBS, food intolerance, gas, and bloating, especially SIBO. And to move on, dysenergic defecation and fecal incontinence. He has pioneered several new techniques and devices and has received several patents. He pioneered the technique of biofeedback therapy for dysenergic defecation and neuromodulation therapy for fecal incontinence. He has received numerous international awards. He's the only physician who has received all the 3 meritorious honors from the American Gastroenterological Association, the AGA Distinguished Clinician Award, AGA Masters Award for Outstanding Clinical Research, and the AGA Distinguished Educator Award. In 2005, he received the highest research award from the American College of Gastroenterology, Auxiliary Research Award. In 2010,
thank you. Don't worry. I appreciate that. We're running out of time.
Yeah.
Thank you, folks. Good evening. I sincerely appreciate ANMS and that wonderful introduction by Prasanna. And thank you all for joining us this evening. My task is to talk about translumbosacral neuromodulation therapy and other anorectal disorders. These are my objectives. Define neuromodulation. We've been talking about this, but exactly, let's learn what is this. Briefly touch on principles of neuromodulation, but particularly focus on neuromodulation application in the lower gut disorders. So what is neuromodulation? It is the modulation or the ability to alter nerve function through targeted delivery using some form of stimulation. We heard excellent talks on gastric electrical stimulation. We also heard on the auricular stimulation. So you can deliver this through a number of mechanisms: magnetic, electrical, chemical, and other means. So whatever means you choose, if you can deliver focused energy to the nervous system, you can change the function or modulate the function, and that's neuromodulation. And the goal is really to normalize what we presume or suspect is abnormal neuronal function. And what is the principle? The fundamental principle is neuroplasticity, which is the body's innate biological ability to learn, adapt, and mold itself. This term was originally coined by Ernest Lugaro in 1906, and really the fundamental principle is the ability of the nervous system to learn, adapt, recover after some form of dysfunction. And this neuroplasticity can be driven by neurostimulation. And the more you stimulate, or repetitive stimulation, it drives new neuronal connections, and improved connectivity is improved functionality, and thereby improved and altered disturbed function. So why do we talk about neuromodulation in the gut? You've already heard two beautiful examples, because the gut is primarily a neurological organ. And if there is a problem with the gut enteric nervous system, you develop a neuropathy. And there are a whole host of enteric neuropathic disorders: gastroparesis, IBS, we've already heard about them, abdominal pain, fecal incontinence, sensitive neuropathy, diabetic enteric neuropathy, and so on and so forth. So there are a number of gut-specific neurological disorders where we can really apply these relatively non-invasive forms of treatment with the hope of restoring normal function. So I'm going to just focus on the magnetic stimulation. That's where our lab has been pioneering, and really talk about the repetitive transcranial magnetic stimulation. Of course, that I will not cover today, because that's more for dysphagia and other disorders, but we'll be focusing on the TNT component. Now, very briefly, I think in the anorectal disorders, there are two other forms of neuromodulation that have already been used. One is, of course, sacral nerve stimulation. And this is done primarily by implanting in the S2, S3 nerves on one side, and then connecting them to a very similar device that Peter was just talking about, the Medtronic's device. Again, there is a temporary pacemaker done for 14 days. And if there's improvement in fecal incontinence, then they go on for permanent placement of this. And the evidence to support this, there is still to date no randomized controlled trial there, unlike the gastric world. But there are some good evidence based on studies such as this by Wexner, and there's one more, which shows that at the end of 3 years, and you can see 100% improvement is about 38 to 40% of patients, and about 75% improvement in another 25 to 30% of patients. Another treatment briefly to mention is the PTNS, or percutaneous tibial nerve stimulation. This can be done a couple of ways. You can actually just place electrodes in these specific areas. We're really trying to stimulate the posterior tibial nerve, or they can also have a fine needle that can be implanted in this. Now, this has been in vogue for almost 15 odd years, and primarily thought to be quite effective in urinary incontinence. And then the best study came out of Charlie Knowles and the British group, where they did a study in multiple centers. They took 227 patients with fecal incontinence, 1:1 randomization, 115 were randomized to the true arm, and then 112 got the sham arm of this treatment. And really, if you look with regards to episodes of fecal incontinence per week, in the PTNS arm, you can see that clearly there is some definite reduction. In the sham arm also there is some, but there's clearly more reduction. If you look at 14 weeks, for example, there's greater reduction here compared to here. Unfortunately, though, the primary endpoint was greater than 50% reduction in FI episodes, and this was not different between the two arms, 38% and 31%. So in this very large study in multiple centers, essentially this PTNS failed. And therefore, I don't know whether there may be subgroups, it may be effective, but so far, I think the jury is out on this treatment. With that background, let's move and talk about some of the work that we've been doing, and let me introduce you to translumbosacral neuromodulation therapy. Now, we all know fecal incontinence is a common problem, it's multifactorial, And what we recently learned is that fecal incontinence is characterized by bilateral lumbo-anorectal and sacro-anorectal neuropathy, which has not been very well characterized until recently, in addition to, of course, what we know, sensory motor dysfunction. So the question is whether neuromodulation therapy with peripheral spinal magnetic stimulation works in fecal incontinence. Before we talk about TNT, let me briefly talk about how we actually do this testing for neuropathy. And for that, what we do, we place a probe in the rectum with 4 ring electrodes, 2 in the anal region, 2 in the rectum. We hook this probe up to a neurophysiology recorder, and then we place a magnetic coil. This is the magnetic stimulator. We place this in 4 separate regions, 2 lumbar and 2 sacral regions, and then we evoke what we call as motor evoke potentials at rectal and anal sites and on all 4 leads. And then we get like 8 motor evoke potentials. How useful is this? In this abstract that we present at DDW, you can just look at the FI group here. We can see the red is the lumbar plexus neuropathy, and then the orange is the sacral plexus neuropathy. So roughly between 48 to 45% have this form of neuropathy. Now, if you look more carefully regionally, it appears that the rectum neuropathy is about 30%, but anal neuropathy is 60%. And likewise, we see a similar spectrum across the board for patients with mixed constipation and also with Levator-Ani syndrome. So these are all neuropathic disorders that we are now able to characterize. So if we believe that neuropathy is an important component of fecal incontinence, then can we change this neuropathic dysfunction? And if so, can we improve their bowel dysfunction? So that, I think, is the question that we asked here. So our goal was to develop a new treatment using this repetitive magnetic stimulation and determine its mechanistic basis. So we took patients with fecal incontinence, at least 1 episode of solid or liquid fecal incontinence on a 2-week prospective diary. Of course, patients with severe diarrhea and neurological issues were excluded. They went through a screening tool. Then they had baseline assessments, including the neuropathy assessment and number of questionnaires. And then they were randomized because we don't know, first of all, whether this treatment works. And if so, what frequency does it work? We just heard the gastric electrical stimulation is a high frequency modality. So we didn't know that. So the higher frequency was 15 hertz. The lowest frequency was 1 hertz. And we chose an in-between frequency of 5 hertz to find out whether this treatment actually works. And we had a number of other standard measurements, including nerve and muscle function and questionnaires and fecal incontinence severity index and so on. How do we actually do this TNT treatment? Well, the subjects come, they essentially lie down, we mark the 4 areas, the 2 lumbar areas and the 2 sacral areas, and then we apply this repetitive magnetic coil that is shown here, nicely sitting on this patient subject. And some of them will wear a headphone or something that does make a tuck-tuck noise, and therefore to try and obviate the noise so they can listen to some music and so on. And really, we are trying to stimulate the lumbar plexus and the sacral plexus nerves with this stimulation treatment. And so we took about 106 patients who were screened. Suffice to say that we landed up with 11 patients approximately in each of the 3 arms, 1, 5, and 15 hertz, and roughly about between 10 and 11 patients completed this treatment. Here are the results. Now, if you look at the number of FI episodes, there was significant reduction in all 3 arms. I mean, all 3 arms seem to be working. In other words, this neural modulation seems to be doing something to the neurological function and thereby improving their physiology and pathophysiology of this disease. But when we look more carefully using our responder definition, which was 50% or greater reduction of FI episodes, there was some striking difference, and that was the 1 hertz had a dramatic response of 90%, whereas 5 hertz was only 36% and 15 hertz was 55%. This told us something, that maybe lower frequency stimulation seems to have a better effect in neuromodulation than the higher frequency stimulation. What about its effects on quality of life? Yes, it does improve coping behavior, embarrassment, and other functions to some extent, even in the 5 hertz, but less so in the 15 hertz. But more dramatically, when we looked at the rectal or anal neuropathy, here is the data for the 1 hertz when compared to baseline. You can see all of these turning red, meaning there's significant improvement in the nerve conduction. Whereas in 5 hertz, you can see there's barely any improvement. There's some in the in the right side, and again, likewise in 15 hertz. So 1 hertz, once again, stands out as the better one. Now, if you look at anorectal function, this is resting pressure, squeeze pressure, sustained squeeze pressure, also some sensory function parameters. They all improved quite dramatically in the 1 hertz, but not so in the other hertz. So we concluded from this that TNT at 1 hertz was clearly superior to 5 and 15 hertz frequency, and it significantly improves fecal incontinence symptoms and quality of life. We saw a multidimensional mechanistic improvement both in neuropathy and in anorectal sensory motor function. And this really raises the very important question, will neuromodulation at low frequency actually help? And it appears to be safe and efficacious, but what we really need is sham-controlled and longer duration studies are needed before we fully accept that. Let me switch gears and talk about the last other problem, a vexing, challenging clinical problem. These patients with anorectal pain, the levator ani syndrome, characterized by recurrent agonizing chronic anal pain. Its pathophysiology is unknown. When you examine them, they're all tender in the anal muscles. So the muscle has been blamed for generations. And people have tried to give Botox. People have tried to inject the muscles with all kinds of stuff. But most of them don't seem to get better. Why? Because we didn't fully understand its pathophysiology. So here our goal was again to study whether there was a neuropathic dysfunction. And this is what we found. We took a large group of patients with levator ani syndrome, and we're studying their anal and rectal motor evoked potentials. This is the left lumbar, left sacral, and right sacral. And you can see when compared to the healthy subjects here in blue, patients with levator ani syndrome have significantly more prolonged motor evoked potentials. Their latency times, both in the rectum and in the anal region. It's actually much more in the anal than in the rectal region. So the question was, well, can we apply TNT to this group and will it work? So we again tried a similar approach. This is a very small study in a much smaller group of individuals. But suffice here, you can see that when we did TNT on these patients, there was significant reduction in their prolonged nerve conduction before and after treatment. This was an abstract at this DDW, but unfortunately we never got to see it, all of you anyway. What about pain, which I think is the fundamental reason why they came to us? And see, in this study, we had 12 patients. This is an open label study, uncontrolled, but you can see there was significant reduction in their subject global assessment of overall pain score on a VAS scale. So to conclude, it appears that this form of treatment may be useful. But before that, what we found was patients with levator ani syndrome demonstrate significant underlying anorectal enteric neuropathy. So this is a neuropathic disorder, and the muscle pain or tenderness is a red herring. And that is one of the things we found with the study. Pain is most likely mediated by neuronal dysfunction. TNT is a non-invasive, potentially promising treatment. Clearly, we need to do better designed, randomized, perhaps sham-controlled studies. I would like to take this opportunity to thank these wonderful people who've helped me in Iowa, who've helped me, continue to help me in Augusta, and thank each one of them, both colleagues, research assistants, postdoctoral fellows, and so on. And these are my final concluding messages this evening. Number one, TNT is a novel, non-invasive treatment, appears to be safe and efficacious. I've given you enough data to support it. We observed significant improvement in fecal incontinence and also in levator ani syndrome. But there is some still questions that we need to ask. Well, can we really demonstrate its improvement against sham control studies? We also need to really look we chose 2,400 stimulations. Is that the right dose? Is 1,200 enough? Or we need 3,600? How many trains should we give? How long should we give this? We currently are doing it 6 sessions, once a week. Is that the way to do? We don't know. How often? What is the durability of response? These are some unanswered questions that we're currently doing in our current NIH study. And hopefully, if John and ANMS invites me again in a couple of years, we can share more information. What I also am excited is this treatment may be useful for other gut enteropathic disorders like diabetic enteropathy, Parkinson's disease, and spinal cord injury. This non-invasive treatment has a role. I hope some of you will be excited by this and go and do this research. Thank you very much for your attention.
Thank you, Dr. Rao, for that great presentation. In the interest of time, it's now the Q&A session. We'll go at least one question through, but the discussion will continue on the ANMS doc matter even after this session. So we have really great questions. So Dr. Kovacic, for you, so one of the questions were there differences in anxiety and or depression in the 60% of the patients that have responded to the treatment versus the 40% that did not respond? If not, which subset of patients do you think this therapy would be of the most benefit?
Yes, I was trying to actually answer this as I got cut off from internet. There was no difference in either state or trait anxiety between the active and sham groups, and it also did not seem to affect these changes with the treatment intervention, but it was kind of imperfectly measured only at the follow-up post-visit. As far as responders versus no responders, there was also no changes as far as differences in anxiety measures on those two. I believe that anecdotally and clinically, you may see some effect on anxiety, but we don't have the data to support that yet. And specific responders, we need more research to sort this out, but there seems to be, we have some preliminary data. I already showed the published data on patients with low vagal tone. I believe there's a subset of patient with an autonomic dysfunction, whatever that may be, is really doing very well with these this therapy. So as far as clinical phenotyping, there's a lot more coming on that. So I really don't know yet.
Thank you, Dr. Kovacic. Dr. Liu, I think you answered some questions offline, but a question for you. So where do you think the GES fits in the algorithm of taking care of pediatrics or adults with gastroparesis?
Yeah, so that's a great question. I think, we still have to remember the one slide, like, these are patients who will likely they may have complications that require surgery. And over enough time, they're going to require at least one battery replacement. And obviously, it's a surgery in the beginning to place it. So I think especially for kids, this would be towards the end of the algorithm, right? So after we've tried our conventional treatment, I think the other thing is after we've given it some time. So, we know that gastroparesis in children is different than in adults. And the majority of kids with gastroparesis do improve, but for those refractory patients, especially if they're still not able to get all their nutrition by mouth, I think that's when we think about, is it worth doing a trial of gastric electrical stimulation?
Great, thank you. Dr. Rao, both these new techniques, what you've talked about, TAMS and TNT, where do you see them fit into pediatric anorectal and colorectal disorders?
I think they have a definite application in pediatric disorders. We may have to do some work in terms of developing probably some smaller coils. I think that is maybe required. These coils are a little big, and if it's a small body, I don't know, they may have a little bit more diffuse stimulation, although they're very focused. They only penetrate about an inch or inch and a half, so they're very good from that penetrability. I think it'll be fine for the children. But I'm a little concerned about the range in which it'll go. So maybe we may need some better coils and also smaller TNT coils. I think that is where I hope there will be some new science coming through with them. I think that's important.
That's great. Thank you for that. We have more questions coming in. We're just about at close to 7 o'clock. I don't want to take it further, but we have our ongoing discussion in the ANMS doc matter community. Please feel free to check in on that. And even this presentation is being recorded, which will be posted on the ANMS website, and there'll be a YouTube link on the website. And we have some great sessions coming up. The next session in November is on functional abdominal pain, both pediatric and adult physicians talking about it. Thank you again for attending today's virtual symposium. Take care.
Thank you, Prasanna. Everybody did a great job. I appreciate that. Thank you.